Okay, thank you for joining us today. Today we have Dr. Timothy Pawlik joining us from Ohio. Dr. Pawlik will be talking about colorectal liver metastasis, the operative sequencing. Thank you, Dr. Pawlik, for joining us, and the floor is yours.
All right. Well, thank you so much, Dr. McGee. I'm really glad to be joining this group again. And Hisham had asked me if I could talk a little bit today about, synchronous colorectal liver metastasis and operative sequencing. So this is a topic that is frequently discussed in HPB circles, is when patients present with synchronous colorectal liver metastases, whether it's better to proceed with a simultaneous operation or a staged operation. And so, typically there are three operative sequences that we think of for patients who have synchronous colorectal liver metastasis. There's a so-called classic approach, which is removing the primary tumor first, and then staging the liver operation in a subsequent second operative case. There's the simultaneous approach, which is obviously doing both at the same time, removing the colorectal primary and then doing the liver resection simultaneously. And then over the last 10 or 20 years, there's been some talk about the reverse strategy, which is doing the liver first, and then after doing the liver, coming back and doing the primary. The liver first approach, or the reverse strategy, is largely reserved for patients with rectal tumors who maybe are getting chemoradiation first, and then while you're doing the liver. But we'll talk about that in a little bit. So with synchronous colorectal liver metastasis, there's sometimes a question of should the primary tumor be resected before starting systemic chemotherapy. This is a problem because if you do that, then you frequently have to delay systemic chemotherapy while they're recovering from resection of the primary tumor. But there's some concern that if you don't take out the primary, that the patient will become symptomatic, and then they're in the middle of getting chemo, and then you have an obstructed or perforated primary tumor, and you obviously don't want to operate on someone mid-chemo. So it's really important to understand, how symptomatic the patient may be with regards to their primary, whether they present with symptoms of a subacute or acute perforation and or obstruction. Typically, even if people have a high-grade obstruction, if you can get a pediatric feeding tube or pediatric endoscopy endoscope through it, then I am still likely to give that patient preoperative chemotherapy first. And only when people are completely, high-grade obstruction, very symptomatic, would I proceed with resecting their primary first. Now, why is that the case? Well, the data are not great, mostly based on retrospective data, but the incidence of having any problem with the primary while the patient is getting preoperative chemotherapy is pretty uncommon, probably in the range of about like 5 to 8%. Overwhelmingly, patients will tolerate the systemic chemotherapy well, even with the primary tumor in. And just as we see response rates in the liver of 50, 60%, even higher now, you'll see responses with regards to the primary. So even some primary tumors that may be high grade that you can fit a pediatric endoscope through, when people get systemic chemotherapy with, FOLFOX or FOLFIRI or whatever, they actually can have a pretty good response to their primary tumor also. And so that's why typically, now that we have such good chemotherapy with cytotoxic agents as well as biologic agents for patients who present with synchronous colorectal liver metastases, I think a delayed approach to the primary tumor is safe and feasible. And as I mentioned, only about 5% will develop symptoms that require any intervention while they're on the chemotherapy. And it's really hard to predict who those individuals who fail are based on like age or gender or tumor location. It's really taking a close history and understanding how symptomatic they may be when they initially present. I think this is important because obviously synchronous colorectal liver metastasis is a systemic disease. And so I firmly believe that the best way of treating it is with the systemic therapy. Initiating primary systemic chemotherapy first makes sense. As I noted, it can sort of reduce both the primary and the disease in the liver, as well as treat any metastatic disease that may be present given that the patient has systemic disease. And if you look at papers that our group and others have published, you can see that in patients who receive perioperative chemotherapy, especially those who have multiple liver metastases, they have better long-term overall survival. Now, you may say that this is due to treatment effect, or you may say this is due to selection bias, but I would say either way, who cares? Because what we're trying to do is select people, right? So if giving preoperative chemotherapy allows me to better select people, that's fine with me, right? And so giving preoperative chemotherapy and ensuring people have a good response rather than progression of their metastatic disease before you embark on an operation of the primary and the metastatic disease makes sense. And this was an abstract that was published recently and presented at ASCO this past year. And this was actually a randomized control study looking at preoperative chemotherapy prior to tumor resection for patients who had synchronous disease. And, I don't want you to read all of this, but they noted for asymptomatic synchronous unresectable colorectal liver metastasis, giving preoperative chemotherapy improve the progression-free survival compared with upfront resection of the primary tumor alone. So I think there's good, kind of face validity to giving systemic therapy to these patients. There's, reasonable retrospective data that supports giving systemic chemotherapy to these patients. And based on this kind of one prospective randomized trial that was presented at ASCO, there's at least some evidence of and prospectively that you should give systemic chemotherapy to patients with synchronous colorectal liver metastasis in order to achieve a better result. So I think the first take-home message is that regarding the operative sequencing for synchronous colorectal liver metastasis, the first thing should be give chemotherapy. And usually I give chemotherapy for about 6 cycles, which is about 3 months. And then when they come back, I restage them, both with cross-sectional imaging and then also with endoscopy, especially if it's a rectal patient, to see what type of response that they've had. And then we make a decision about the surgical approach. And again, get back to whether we're going to do a classic, simultaneous, or a reverse strategy. And the decision about what approach to adopt, I think, depends on several factors. One, the primary tumor location. Specifically, I would say whether it's a rectal versus a non-rectal tumor, I think makes a big difference in my mind. Where's the location of the liver metastasis? Is it all in one hemiliver or is it bilateral? And what type of extent of surgery is going to be required both for the colon and the liver? Because I think, as we'll see, like doing a big liver operation and a big colorectal operation can kind of lead to more complications compared to like a small colon, like a right colon and a big liver, right hemihepatectomy. The incidence of complications is going to be much lower. And then obviously the patient needs to be considered, like their performance status. Are they frail? Are they old? Can they kind of like take a joke, so to speak? And if they have a complication, are they going to be able to get through it? So old and frail people, I may be more inclined to do a staged approach rather than a simultaneous. Mohammed, did you have a question? I saw your hand went up briefly.
I think that was a like.
Oh, okay, great. Okay, so simultaneous versus stage. I think, as I've alluded to, I think I have this whole notion of like big versus big, small. So I think, if you're doing a big hepatectomy, like a right hepatectomy extended left, and a small colon, then I'm inclined to do that simultaneous. Similarly, if there's a small liver resection, like a wedge or segmentectomy, and a difficult colon, like an LAR, I'm inclined to do that simultaneously also. The things that give me pause are like a big liver resection, like a right hemihepatectomy, and then like a difficult LAR or a difficult APR. I think the risks there make things higher. And, I think I only would do that in very well selected patients who perhaps are younger or have better performance status. And here are some data that we published a while ago. And you can see here that in patients who underwent a minor operation, when they had either a simultaneous or staged approach, the overall complications were about the same. But when they had a major hepatectomy, when it was simultaneous, you can see that the risk of complications was higher. The overall survival was no difference in these patients. So long-term, whether you take it out staged or simultaneous doesn't seem to matter, but the perioperative risk could be a little bit higher. This is a different study that was published in Annals of Surgical Oncology, about 5 years ago that we published. And in this study, it was a meta-analysis. And in looking at multiple studies in the literature, you could see here that the morbidity and mortality associated with the staged operation was a little bit less, about 25, percent risk reduction in morbidity with a staged operation, but no difference in mortality. All of these cross the confidence interval, or the cross one. And the same thing goes for survival, no difference in survival. And so this is kind of a larger table that demonstrates the median survival and the 5-year survival, looking at patients who had simultaneous versus stage. And again, you can see no real measurable difference in most studies. There may be some suggestion that in simultaneous, in some studies, it was a little bit lower, and that's probably a selection bias, right? Because if you did one operation, then you didn't have that time that the other patient had that was staged. Because inevitably, when you have a staged operation, there will be some people who progress between stage 1 and stage 2, and then they drop out of the survival curve, right, when you're only looking at surgery. So simultaneous, you have less selection, right? Stage, you've waited a period of time and you've only taken people back for the second operation who didn't progress from the first stage. One thing that we looked at was this idea of textbook outcome. And this is this composite measure of like an ideal or optimal outcome, whereby you don't have any intraoperative complications that are higher than a grade 2. You have a R0 resection. You have no liver failure or bowel leak. You have no 90-day mortality, no readmission, and no major postoperative complications. And this is defined as a TOLS, a textbook outcome in liver surgery. You have to have all of these things. And interestingly, if you look, again, for patients who underwent a stage resection, the incidence of a TOLS, so a textbook outcome in liver surgery, was higher at about 65% compared to 58% for people who underwent a simultaneous operation. And you can see here the different factors that contributed to that difference in the TOLS, one of which was major complications. So it was about a 2-fold higher incidence of major complications than simultaneous. And then, that resulted in a lower composite TOLS outcome for simultaneous individuals. And you can see here the adjusted probability of the TOLS also is a function not only of the type of operation, but also, as I mentioned, the patient's age. So, how maybe frail or how much they can tolerate one operation. And you can see that patients who were older tolerated a simultaneous operation less and less. And their probability of having a TOLS with the simultaneous operation was worse. Again, suggesting that perhaps in more frail or elderly patients, a staged approach is more appropriate. And this is a bar chart showing what I had alluded to earlier about this low-risk colectomy, low-risk hepatectomy. So we stratified TOLs based on these 4 categories. And not surprisingly, you can see that in patients who had a low-risk colectomy and a minor hepatectomy, the incidence of TOLs was roughly the same, whether you did it staged or simultaneous. And you can see the main differences when you had like a major hepatectomy or a high-risk colectomy. You can see here that the risk was much higher when you did it as a simultaneous than if you did it in a staged approach. These are some other data looking at length of stay and charges. So the one benefit of a simultaneous is that if it goes well and you don't have any complications, it's only one anesthetic, it's only one hospital admission. So it tends to be cumulatively fewer days in the hospital because it's not 2 hospitalizations being added up. And therefore, it also translates into being more cost effective. The problem is the benefit is washed out if patients who undergo a simultaneous procedure end up having a complication, because then they're in the hospital much longer and that costs a lot more money. So that's why patient selection is so critically important. And this is a paper that we published in Surgery that looked at preoperative morbidity and the impact of tumor burden. So how can we select patients based on tumor burden? So we have proposed previously this idea of the metro ticket for colorectal liver metastasis. And this is a similar notion to what has been popularized for hepatocellular carcinoma. So the idea is the metro ticket. You pay more in the metro the further you want to go, right? So the idea here is as tumor burden increases in the liver, you're going to have to pay more. And what's that cost? Worse outcomes, right? Worse overall survival, worse disease-free survival. So we have proposed a composite score based on tumor diameter and the overall number of lesions in the liver that comes up with this composite TBS, tumor burden score. And what we have shown here is that this tumor burden score is actually a pretty good indicator of risk of complications. And you can see here that at about a threshold of 9 for the tumor burden score, overall, the complication rates are roughly the same. But once you get a tumor burden score that's past 9 or 10 threshold, the complication rate goes way up. And the reason for that is probably because you're having to do a much more extensive either multiple wedges, multiple ablations in the liver to deal with all of this disease. And you can see this on the right, is that in patients who have a low TBS or even a medium TBS, there's no difference in the complication rate. But when you get to a high TBS patient, simultaneous, there is markedly more complications. So I think as surgeons, this is one thing that we can use, right? You see a patient with synchronous colorectal liver metastasis, and you're trying to decide simultaneous or stage. Well, you can calculate their tumor burden score, and if it's over 9 to 10, then you might think, maybe I should do this in a staged approach. The other thing that we have done is use machine learning to try to come up with algorithms of when one should use a staged or simultaneous approach. And in this study, AI identified that one of the primary factors is the location of the primary tumor, whether it's a right-sided lesion or whether it's a rectal lesion. And if it's a rectal lesion, then, simultaneous approach is associated with higher complications, and you might want to consider staged. After the site of the primary tumor, the next thing that artificial intelligence identified was the tumor burden score. As I noted, what's the burden of disease in the liver? If it's high, again, stage resection, lower risk of complications. But if the tumor burden score is low, then you kind of proceed down a pathway where stage and simultaneous have more comparable risk of complications. So I think this is helpful clinically when trying to decide, is it a rectal lesion, non-rectal lesion, what's the tumor burden score in the liver, and that'll help inform. The other thing that we recently published is biology. And as I mentioned before, the benefit of the staged operation is you have more time to let biology declare itself. So this is a paper that I think just got published maybe a month ago, and we looked at the role of KRAS status among patients undergoing staged or simultaneous resection for synchronous disease. And in this study, what we found is that in patients who had KRAS mutated tumors, and a high TBS score, that patients who underwent a staged operation did significantly better. And again, why? It's simple, because these are high-risk patients. They're likely to progress. So you're better off kind of letting them, have more time to figure out if they're truly going to benefit from an operation or not. So that's something else that I use, is their KRAS status in conjunction with the TBS score to try to figure out and decide whether I should proceed with one operation or not. And then what about the rectal tumor? I kind of alluded to that if people have a rectal tumor, especially when you're doing a major operation, that perhaps this is best done in a staged approach. And for rectal cancer, it's more complicated because treatment of the primary rectal tumor is more complicated and typically can involve not only surgery, but chemo and chemoradiation to the primary tumor. And since patients are living longer and longer, even with metastatic disease, local control of the rectal tumor is very important. And therefore, getting the kind of the radiation in, if you will, can be important. So that's where this kind of reverse approach kind of comes in, is that, if you do the primary first with the rectal cancer, it's more complicated. The risk of a leak is higher, pelvic sepsis may be higher. And if that happens, then the patient's not going to get chemo for a long time. You've missed your operation to clear the liver. So, the proposal has been, well, why don't we clear the liver first? Why don't we maybe give chemoradiation to the pelvis? And then, when the patient is recovering from that, we operate on the liver because, even though there's a risk of complication, generally the risk of liver complications is pretty low nowadays. Then they can recover from that, and then they go back and do the rectal operation. So that is the rationale behind this reverse approach, is treatment of the liver disease is not delayed by treatment of the local rectal tumor. And as I mentioned, this reverse approach is largely for rectal tumors. You give the systemic chemotherapy, as I mentioned, then maybe chemoradiation therapy, and proceed from there. And this was really, I believe, first approved by Professor Mentha, who, in a very small cohort of 20 people, demonstrated its feasibility and pretty good outcomes at 3 years. And so this is kind of an algorithm of approach: give chemotherapy, do the liver resection, then give the chemo rads and do the rectal operation, and then consolidate with more chemo. Or you could do chemo rads, and then while they're waiting their 4 weeks for after their radiation, you do the liver resection, and then the colorectal surgeons go in and do the rectal operation. So here's a case of mine. So this is a 45-year-old gentleman with blood per rectum. He had a rectal mass, and then CT scan, you can see here, showed multiple masses, mostly in his right liver, but maybe a little bit down here, kind of close to the caudate lobe, and up by the middle hepatic vein. He got a PET scan. It showed multiple lesions in his liver, and it lit up the rectal tumor. So his rectal lesion was, kind of near obstructing, but they were able to put a rectal stent in. He got treated with Zelox. He got volumetrics, and his volumetrics were a little bit low at 17%. So then he went and got a PVE of his liver, and actually had pretty good hypertrophy, the 24%. And then had significant reduction of his disease in his liver, but still, had encroachment on the right vein and the middle vein, and needed kind of an extended right. We were able to preserve most of segment 4, but we had to take the middle vein because of where the tumor was. He also got chemoradiation to the rectal tumor before I took him to the operating room. And then after his rectal radiation was done, I went and I did this right hepatectomy, as I noted. You can see here, and you can see post-hepatectomy, pretty big hypertrophy of his left liver. And then they went back and did a second stage low anterior resection. The colorectal surgeons did, and his pathology showed T3N1. He got additional adjuvant Zelox and is still alive and disease-free about 3 or 4 years later. So, this reverse strategy has caught on a little bit. It still doesn't account for the majority of operations for synchronous colorectal liver metastasis. But in those patients with rectal tumors, it's definitely something to be considered, as noted. The other thing that I think to keep in the back of your mind is, the 2-stage hepatectomy. So sometimes what can happen is that patients will have bilateral disease, and when they go in to remove the primary colorectal tumor, you can debulk or clear one side of the liver, right? So say someone had, a right primary tumor, they had extensive disease in both sides of the liver. They're not a candidate for a single stage hepatectomy because the extent of their disease and location of their disease. Then they could go in, they could do maybe like a lap right hemicolectomy. Laparoscopically, you could clear the left liver. Then post-operatively, the patient gets a PVE, and then the remnant left liver hypertrophies, and then you come back for a second stage completion right hemihepatectomy. And that is something that we not infrequently do if we're not able to clear the liver in one stage. I think something else that has really changed the landscape is the introduction of laparoscopic and robotic surgery. Before, to do a simultaneous approach, if someone had like a sigmoid lesion, let's say, I mean, you'd kind of open them up stem to stern, right? This huge incision, it's very morbid. But I think now with robotic approaches, it is a game changer in that, both the primary and frequently even the liver can be removed from a minimally invasive approach. And we did a systematic review looking at this, and you can see that this is very feasible, low conversion rate, low complication rates. And I think in most centers now, a robotic or laparoscopic approach is utilized very frequently in the setting of synchronous colorectal liver metastasis. And you can see here that the overall results are quite good, whether it comes to the colorectal resection or liver resection related complications, both very low. I think the other reason why the complications are so low, in my opinion, is in the past, many times it was the same surgical team doing both. But now at most large academic medical centers, there's a dedicated colorectal team and a dedicated liver team. And, I do my operation, they do their operation. So they come in, they're doing the LAR, they're doing the APR or whatever, and then I'm doing the liver. So I think that we have, a different kind of level of expertise and collaboration in the operating room nowadays that provides for excellent outcomes. So this is a review that we published fairly recently, I think within the last year, that I'd recommend you can check out, that discusses many of the things that I've been talking about today, kind of what's the current state of the art for management of synchronous colorectal liver metastasis. And although I'm always kind of reluctant to show algorithms because they tend to oversimplify things. Here's one anyways. So, for patients who present with synchronous colorectal liver metastasis and primary disease, I think making a decision whether the liver metastases are resectable or not. Obviously, if they're not resectable, you proceed to chemotherapy and then iteratively reassess the patients to see if they've converted at all and moved into the resectable cohort. For those patients who you believe have resectable liver disease or borderline resectable disease, as I've noted, I really think preoperative chemotherapy is the way to go, as long as the patient is not very symptomatic from the primary, and then restage that person and assess them whether they're a candidate for a simultaneous resection. And as I have noted, the things to consider is the risk of their primary tumor. Is it, right colectomy? Is it a sigmoid? Is it a difficult LAR or APR? Also consider the extent of the liver procedure. And you could use tumor burden score as a proxy for how extensive the liver resection will need to be, with a threshold cutoff of about 9 to 10. And then also consider the biology of the liver metastasis using KRAS mutation status, which will help you understand whether the patient would be at risk for quick progression, which might suggest that you do a staged approach. And then finally, also consider their performance status. I showed you data that as people get older, they're less likely to tolerate a simultaneous approach, especially if it involves a large liver resection and a complicated colon resection. And then also keep in your armamentarium that not all liver disease needs to be resected, but there may be instances where you combine resection with microwave ablation and or a two-stage hepatectomy itself. So with that, I'll conclude, and I'll be happy to entertain any questions. Hopefully this was helpful and provide some, meaningful, real clinical information for you when you see patients with simultaneous colorectal liver metastasis in your clinic. So, Hisham, thanks again, and happy to answer any questions.
Thank you, Dr. Pawlik, for your talk. Very interesting as usual. We can now take questions. Please, if you have a question, raise your hand. If you have any question, please raise your hand and I will give you the mic. It was a straightforward talk, so I wouldn't be surprised if there were no questions. Does anyone have a question?
Any thoughts, or people with synchronous colorectal liver metastasis any different, the same, or?
Okay, Dr. Ehab Sayad. Ehab, unmute.
Okay, thank you about the lecture. I want to ask about the protocol of concurrent chemoradiation before the start of the liver resection. Do you prefer long course radiotherapy or short course radiotherapy, or you don't have any special comment about this?
So the question's about the radiotherapy to the pelvis?
Radiotherapy in the cases of the cancer rectum?
Yeah.
Metastatic cancer rectum. Some oncologists here in Egypt prefer not to do, you say it's a systemic disease, so we don't give radiotherapy in these cases. At your side, you give radiotherapy for these cases. I think you said that, but you prefer protocol for radiotherapy, short or long course, or you no preference for this?
Yeah, I think if we're in a curative paradigm and our plan is to resect all the disease in the liver and to resect the rectum, I think there are data to suggest that the incidence of local recurrence for rectal cancer is decreased with the use of radiation therapy. So we would use radiation therapy because we're still in a curative paradigm. And as I mentioned, people who have metastatic disease, many of them live for a long time. and a subset don't recur in their liver, but to have a pelvic recurrence can be challenging to manage, and it also can be very adversely impact people's quality of life. So local control is important.
Okay, thank you. Another question.
Okay.
Yes, go ahead.
I'm asking. You said that you prefer in the cases of the cancer rectum to start with systemic chemotherapy in metastatic disease, or to start, sorry, with the liver first. Okay. This also goes with the cases of low anterior section or just for the ABR cases?
Yeah, so that's a good question. So let me clarify. I don't know if I did a good enough job. So like if they need like a low low LAR and APR, but the liver is like easy, like there's a something in segment 3 or something, and it's easy to wedge out. I think you can do that simultaneous, right? You know what I mean? That's pretty straightforward. I'm talking about like if someone needs a right hepatectomy and then they get a difficult APR. Like, I don't know about that. You know what I mean? Like, that's a lot to put someone through. And a lot of it depends, like I said, on the person's age, performance status, even their habitus. A man, big man with a, narrow pelvis, and it's going to be super challenging and, things like that. So I think it's like case by case. But if someone had a challenging rectal lesion and needed a formal right hemihepatectomy or extended hepatectomy, those are the instances where I would entertain like a reverse strategy.
Okay. Thank you, Melissa.
You're welcome.
Okay, any other questions? Please, if you have a question, raise your hand. Dr. Gamal Amira, do you have any questions?
What is the role of HIPEC in cases of colorectal metastasis and peritoneal disease?
Yeah, that's a good question. So I think selectively, patients who have low burden of disease in their abdomen, that there is a role for, I would say, peritoneal debulking. The role of the chemotherapy, I think, is a little bit more questionable. Like, what's the true benefit of the hyperthermic chemotherapy? But I definitely think that there are some patients who have gotten systemic chemotherapy, have low burden of peritoneal disease, who benefit from, cytoreductive surgery.
Yes, but liver disease per se is not indication for HIPEC. Should be peritoneal disease.
Yeah, sometimes there can be some implants on the liver, right? So
Yes.
that's different than like a parenchymal lesion.
Mhm.
That I would think is more kind of like bloodborne disease, right? So, people who have actually parenchymal lesions of the liver and peritoneal disease, I think that those patients, it's very unlikely, that they would benefit from an operation. I never say never, right? Actually, I just saw a patient in clinic this morning who had a distal pancreatic adenocarcinoma with liver metastases, and she's like 5 years out and disease free. I did a distal pancreatectomy on her and did a couple wedge resections for liver metastasis. She was heavily pre-treated with chemotherapy, and I waited a long time. I might even waited a year, but it was stable. And then I finally said, okay, it's been a year and it's stable. I'll go in, I'll take it out. And she's alive. So but I'm not going to like rush in there, right? But if someone had low burden liver metastasis and low burden peritoneal disease, and they got heavily pre-treated with chemotherapy and it was stable and they were young, you know what I mean? Like we do things. But it would have to be super selective.
Thanks.
Yep.
Any other questions? Last call for questions to Dr. Tim Pawlik. Any question? Okay, so looks like that was it.
All right. It's
As
always good
usual,
seeing you all.
yeah, we had fun and always a pleasure having you with us. Are you coming to Egypt anytime again soon?
Not that I know of. Not that I
Okay,
know of. I'll
let's see.
not good, but when I come back, I enjoyed my visit there, I guess last year. Wonderful country, and Cairo's a
Yeah.
wonderful city. So I'll keep you updated.
Okay, thank you everyone, and good night, and see you next webinar. Good night.
Okay, guys. Bye-bye. Thank you.
Good
Bye-bye.
night. Bye.
Bye-bye.
Bye.